afternoon, everyone. I really appreciate being invited to speak at this event, and sorry I cannot be there in person, virtually, if that's the right way to put it. Of course, the best thing of all would be to come to Uganda and meet everyone, and I do look forward to when we can travel again. We're getting better and more proficient at working virtually, but we do need some face-to-face as well. So by complete coincidence, today is also the date of the second Global Health Symposium of Global Health Education Ireland. And as I'm one of the organisers and speakers in that, I've had to give that priority. And like this event is global in terms of participation, and we have several speakers from Africa, including from Uganda. So this event is certainly timely and important. If we had no pandemic, we would likely be having an event anyway on the theme of UHC and reflecting on 5 years' progress in our journey to 2030. The pandemic has changed so many things for us, and it is doubly important, I think, to have these discussions. So I've been asked to speak about the decade ahead for health workforce strengthening. I would speak mainly from some of the experiences we've had with COVID-19 and what this shows us we need to do over the next decade. You are, I expect, all familiar with the Global Strategy for Human Resources for Health, Workforce 2030, which was adopted in 2016, shortly after the adoption of the SDGs. And the analysis in that strategy is stark. A projected deficit of 18 million health workers by 2030. And that in itself is enough to indicate the huge scale of work needing to be done. And the strategy, if you recall, has 4 objectives. And just to remind you of these, the first was about optimizing the performance, quality and impact of the current workforce. The second was about the additional workforce that's needed and how to invest in the education and training of the workforce and creating the right conditions for employment. The third objective is about building capacity of institutions that are needed for health workforce stewardship, leadership and governance. And fourthly, the fourth objective is to strengthen data on human resources for health. Now, in the first session this morning, you addressed the question of how health systems can recover from the COVID-19 pandemic and to continue with commitments towards UHC. So I'd like to continue in that vein in looking at health workforce issues. So a few observations just on COVID-19. Firstly, I think it would be fair to say that COVID-19 has exposed weaknesses in health systems everywhere, across all regions, all countries, at all stages of development. Our health systems are not as strong and resilient as we would want. And my own country, Ireland, is a case in point. We're one of the biggest spenders globally in healthcare, but we've been found wanting with deficits in our public health infrastructure and intensive care facilities in our hospitals, for example. And further, we have seen everywhere how health services have been disrupted by COVID-19. There's been an impact on all essential services, and perhaps in Africa, the impact of this has been felt more than anywhere. And it's a particular concern. And I'm sure you've read many of the reports that point to the estimates of future illness and mortality as a result of COVID-19. So not just direct effects from COVID, but indirect effects on healthcare and from the restrictive measures in society. It's also been interesting to observe how the COVID-19 crisis has countries caught up in trying to protect themselves. And I think we need to be reminded of what COVID-19 is showing us is how interdependent we are and need to be, and how much it's in all of our interests to strengthen health systems everywhere. And WHO keeps reminding us that we are only as strong as the weakest link and that we are all in this together. So there's a constant global governance challenge, and that's certainly the case with the health workforce, where we need better global cooperation with our very globalized workforce today. So I'd like to mention some of the lessons that strike me from the pandemic for the workforce looking at the years ahead, and maybe to relate those to the objectives of the global strategy that I mentioned earlier. And first to say how the disruption to services has really shown how thin our service capacity is. and how this needs to be addressed. We weren't able to cope with the surge in demand, and a lot of our services stopped. So the need for more health workers is so apparent. And it remains one of our foremost challenges to increase investment in education and training of health workers and to create the fiscal space so they can be employed to deliver essential services. So we have to keep telling that message. Achieving universal health coverage requires accelerating investment in the health workforce. And when you look at the total investment needed, one of the biggest areas is the workforce. And this is what the second objective of the strategy speaks about. So going back then to the first objective, and as I mentioned, this is about optimizing the performance, the quality, the impact of the workforce. And a few things strike me here. I see a need to strengthen capacities in public health with more public health professionals. We see decisions being made in the pandemic which have huge consequences for the health and well-being of populations and societies and economies. We need more public health skills to guide decision makers in these big decisions. We need people who can look at health in its totality of physical, mental, and social well-being, and not just focus on controlling the disease that we face. We need people who can do health impact assessments across all sectors, including education, employment, and business. People who can analyse connections between health and the economy and balance healthcare measures with broader societal measures to deal with health crisis. Now we need that now for COVID-19, but in fact we need it for all aspects of universal health coverage. Another thing the pandemic has highlighted is the importance of communities in healthcare. We've seen so many issues that have needed to be addressed at the community level. Providing health information and correcting misinformation, enabling behaviour change, looking out for vulnerable groups, helping people with chronic diseases to continue to access the care they need. And we know the solution for universal health coverage is a strong primary healthcare-based system. So in the coming years, we need to strengthen investment in the health workforce that can implement this approach. So that's going to require continuing the focus on health workers who are based in the community and working at local facilities. Another aspect that I think the pandemic has brought into focus is how much we need to support health workers in their work, and they need to do this better. And we know frontline health workers are already often working under lots of pressure, sometimes working with inadequate resources and facilities. And now with COVID-19, there's the added pressure and stress of safety and psychological pressures from the demands of the pandemic. And so we need to address this. And if universal coverage is about quality healthcare, we need well-performing, high-performing health workers. And to achieve this, they need to be better supported. So we need to invest in measures to support the general health and the mental health and well-being of health workers. And thinking a bit further about this aspect of mental health, we've seen with the pandemic the huge mental health strains on people affected by COVID-19 and the measures such as lockdowns and social distancing, with social isolation, domestic violence, and so on. So more investment is needed in health workforce to deliver better mental health services, which are under-resourced almost everywhere. And then the global workforce needs to be managed better at a global level. And COVID-19 has reminded us of the inequalities in healthcare between countries, which is compounded by migration. The health workforce today is mobile, and we have to do better at managing migration. Nearly every country both sends and receives health workers, and what each one does has an impact on others. And continuing migration from low-income countries to high-income countries has a negative impact on the countries of origin. We need to continue to implement the WHO Global Code on International Recruitment of Health Workers and use other platforms, such as the International Platform on Health Worker Mobility, which emerged following the UN High-Level Commission on Health Employment and Economic Growth. And that brings me on to the third objective, which is about building the capacity of institutions for planning, stewardship, leadership, and governance of actions on human resources for health. To implement all the things that are referred to and others, we need institutions to be established and equipped with people with special skills in HR and leadership to plan and implement measures. And here I'd note that the Leadership Hub in the Global Health Workforce Network is making good progress in developing training opportunities in this area. And then finally, to say something in connection with Objective 4 of the strategy, to strengthen data on human resources for health. And clearly the pandemic has shown us how essential it is to have good data for decision making. We need it for disease surveillance, epidemiological modelling, outbreak management, information about vulnerable and susceptible groups, and so on. We also need better data for the health workforce as part of strengthening and building comprehensive health management information systems for universal health coverage. So I'm going to finish there, and I hope these few reflections have been helpful and will stimulate the discussion in the panel session which follows. So thank you very much for letting me to speak today.
Many grateful thanks to Dr. David William, who is the board chair for the Global Health Workforce Network. At this point in time, I take the pleasure to invite the founder of the Global Health Workforce Alliance, the World Health Organization, who has served in many different capacities in promoting global health, but also in workforce development in our country. And that is none other than Professor Francis Omaswa to chair the next panel. Professor Francis Omaswa, the floor is yours.
Good afternoon. Good morning. It's so nice to see so many friends. Nigel, David, I shouldn't start listing them, I'll get into trouble. So it's great to have this partnership and this meeting, which is our second meeting. And I'm really been following from the beginning. I love the reference to global solidarity. I was very much impressed by the statement some weeks ago by Boris Johnson, sort of on this topic. And we look to the leadership of the UK government in being able to support countries like ours in the global market. It is so important, and we appreciate this partnership very much. So the panel I'm going to chair is on health workforce, which is one of the key pillars to achieve everything that we aspire to. And this also, to me, is an opportunity for us to cement our partnership, Uganda and UK, on this topic. As I recall, the last conversation I was having, we were having on this was not a pleasant one. It was about those recruiters who were looking for health workers from Uganda and other African countries. And we went on to write about this, hoping that we would start to build a partnership based on the WHO code on the international recruitment of health personnel, which would give us an opportunity to share equitably and productively the health workforce that you have in the UK and that we have in Uganda. I'm hoping that our conversation today will, to some extent, go in that direction. So without much ado, I would like to invite the first speaker. And I think I've lost my program here. It is the first speaker on this is going to be Ben. And Ben, I saw you earlier. Please give your presentation.
Thank you, Professor Maswa, and congratulations to the organizers. It's been a fantastic morning. Rather depressing when I think about the statistic shared by Dr. Jonas from the World Health Organization, but nevertheless, optimistic. And I hope I'm going to be able to strike some optimistic notes in my few words. First of all, I too, like Lord Crisp earlier, would like to acknowledge the pressure that health workers are under at this time. I think it's important that we recognize that, and the physical and psychological jeopardy that many health workers are in. Indeed, when the pandemic began, or the syndemic, as I prefer to call it, borrowing the phrase from the Lancet, when the syndemic began, my expectations were that our partners in the UK would retreat into their day jobs, that they would be absolutely focused on the COVID response. And when I was asked by people in those early weeks, what is happening in terms of health partnerships, in terms of links between the UK and Uganda, I said, what do you mean? Of course, nothing's happening, because everyone is busy on the day job. And then I started receiving texts from people saying, the day job is a nightmare. We've never been under such pressure. We feel under-resourced here in the UK, but my word, how are people feeling in Uganda? And then I realized that actually those ties of solidarity between Uganda and the UK are so strong that despite the pressures, there was all this activity happening, all these conversations happening. And I think that that speaks to the strength of the relationships between the individuals and the organizations. And I'm delighted that we're surrounded at this seminar by people who are the living proof of those expressions of solidarity between institutions and individuals. It's very positive. We were able at FET to award some grants to support the COVID response. And I think one of the great things that we'll be celebrating, documenting, is the way in which existing partnerships adapted to the challenge of COVID. And I'm thinking, for example, of the work we were doing on antimicrobial stewardship, and some of our partners, for example, in Cambridge, who adapted brilliantly to the challenges of COVID. And in other ways, our relationships have been transformed for the better. We talked about internet connectivity, and I accept that, and I don't want to deny the truth of that. But on the other hand, the drive to digitalization has been an extremely positive element of the COVID reality. And I use the phrase, as do others, I'm sure, but made necessary by COVID, but inevitable by climate change. We're getting a greater fluency in terms of uses of technology, which will enable us to reduce our dependence on flights. I blush with shame when I think about some of the short visits I've done in the past. Blended learning, blended approaches using technology and in-person contact, I think, is one of the great things that we can welcome as we evolve our approach to exchanging expertise, to bilateral, bidirectional learning, etc. My main grounds for optimism as Chief Exec of FET is that we have been able to announce this new funding scheme, and I've put a link to that scheme in the chat box here, but also tweeted about it. And this is the largest investment of funding for health partnerships that we've seen since 2011. So it's a big and significant moment. The programme as a whole is £20 million. We expect at least £2 million of that to flow into Uganda. And there are variations. There are smaller grants that can be applied for, which perhaps have a particular emphasis on innovation or in supporting new partnerships to strike up relationships. And then there are larger grants. And at the heart of the larger grants, if you look at that link, is a set of detailed criteria about what we'll be focusing on. And we've been working with the Liverpool School of Tropical Medicine in terms of refining those priorities, but also much more significantly with the Permanent Secretary and with the Ministry of Health. And so those priorities flow from those conversations with Diana and with others. And it's rooted around three areas: health information and data systems, strengthening human resource performance, and strengthening community health systems. So please do check out that program of grant making. There'll be a very strong nursing element, picking up on the themes that are close to Nigel's heart and which have been so exciting in recent years through the Nursing Now campaign. Nursing will be a big part of this. And if you think about strengthening community health systems, for example, then it's a statement of the obvious that we'll expect to see a strong emphasis on nursing. I think that the other thing I celebrate from my position is just that we are beginning to acknowledge the complexity of all this. And I'm grateful to Francis for emphasizing the challenges around migration, the challenges around the behavior of recruitment agencies, etc. This is a theme that really matters to FET, but acknowledging the complexity is really important, isn't it? So we've got that figure that David gave us. What is it? 18 million health workers we need by 2030. My goodness, it feels like the day after tomorrow. By the way, a shortage that is being lived in the UK as well as in Uganda. It's just that it's disproportionately a challenge in Uganda compared to the UK. But also, I tweeted the other day a statistic from WHO Africa office. We interviewed one of their members of staff. And did you know that there is unemployment of at least 700,000 health workers across Uganda? So we've got this shortage, this recognition that Africa has less than 30% of its required health workforce in employment. And yet there is this unemployment. So something's going on. And who are we to criticize the individual who seeks to improve their well-being by seeking employment elsewhere? I'm sorry, the organizers just did something to the screen which kind of distracted me. So acknowledging the complexity of workforce, of migration, it seems to me is a great move forward. And we try to do this at FET also through our article from our policy paper from Competition Collaboration, which I've also just posted in the chat box. And that tries to say that we need to move on from this competitive approach whereby we compete with, well, the UK, with Australia, with America, whoever it is, with Uganda for access to health workers. We need to move from that to better cooperation, recognizing that we have these shared challenges. And the themes in from competition collaboration very much pick up on those. And I know those are really important to our chest. And I want to acknowledge the sort of pioneering thinking that Francis Amazwa and others have been responsible for. I also say that within the landscape of UK-Uganda partnerships, there are also some very, very exciting initiatives happening. Health Education England, who we haven't really heard enough of so far this morning, are really supporting some very, very pioneering approaches. I'm thinking about the work John Paul Pagala is doing on exchanges of health workers between the UK and Uganda, looking at maternal health in particular. There are a number of initiatives which are really worth celebrating. So I wanted to say that this is the territory where I look forward to exploring. It's recognizing the complexity, but recognizing also that we are in this together and we have a shared challenge in terms of increasing the numbers of health workers, increasing the quality of training, working in ways that acknowledge the climate crisis we're in, acknowledge the common challenge of pandemics such as COVID, and celebrating that actually I've been able to announce today more funding available to support UK-Uganda relationships than we've seen since 2011, which is I think a cause for celebration. So thank you very much for inviting me to speak. I'm delighted, I must say, to be joined by my colleague, Dr. Shiba Gita, who represents us and in Uganda and knows much more than I do about the reality of Uganda. Thank you.
Well, really, very incisive discussion there. What you have pointed out, complexity of this issue, was the original reason why it was neglected. They said it's too complex, leave it to the government. But at least now it is on the global table and we are in it together. Those are very moving words indeed that you have put before us. All those issues, how can we solve those issues together? So let me now invite my good friend from Birmingham area, Professor Lisa.
Thank you so much, Professor Francis Maswa. What a treat it is to be with you here today. And this is a common theme actually for me with my connections with Uganda. And in spite of all of the, the dreadful things that are happening with COVID-19, being the programme director for the Nursing Now Nightingale Challenge is not only one of the highlights in my career to date, but also it's helped me through this dreadful time, because what has been so amazing has been the ability to bring nurses together, to connect on common issues, and to have really meaningful conversations about how we need to build the capacity and capability of the nursing workforce globally and to raise its status and profile. And I'd very much like to pay tribute to Lord Nigel Crisp, Professor Sheila Clow, Professor Francis Maswa, and so many more, in particular the Nursing Now board members that have also been part of this sort of social movement that's really, over the last 2.5 years, galvanised nurses and midwives from all over the world to come together to really think about how we can make more of a difference, how we can be taken more seriously, to attract more investment and to be at the policy decision-making tables. And great progress has been made. And Uganda has been a leading light for us in that in many ways. It was delightful to come to visit you when we could back in February, and the support we had from you, Professor Francis, and also the Ministry of Health and significant nurse leaders to have serious conversations about what we need to do to change the direction of nursing was heartfelt. And I was incredibly impressed by leaders in Uganda, such as Beatrice Amugo, that was the chief nurse of the Malago Referral Hospital, that now I understand is one of the commissioners in the Ministry of Health. So that just goes to show the significant player that you've got in Uganda that's driving forward the agenda. But a little bit now about the Nightingale Challenge, which is the element of the Nursing Now programme that I've been leading. We launched the Nightingale Challenge back in June last year, and the aim initially was to get 20,000 early career nurses and midwives, young nurses and midwives, through their employers engaged in leadership and development activities that would improve their clinical practice, their ability to be strong advocates for patients, and help them to become more influential within the communities in which they'd work. Well, I'm delighted to say that not only was Uganda one of the early adopters, and you have over 270 young nurses and midwives on the Nightingale Challenge across Uganda, but across the world, we've got over 30,000 young nurses and midwives that have convinced their employers that they're worth investing in, they're worth this opportunity to be developed, to be upskilled, to be used and build their capacity and capability, which is what we've heard about so much this morning through the other eminent speakers. And we're also in nearly 80 countries. We're 79 countries at the moment. So across the world, we've now got this amazing community of young nurses and midwives that really want to be change agents. And throughout this sort of last 6 months where it's been incredibly challenging, what's been really evident is that young nurses and midwives are up for this challenge. Yes, they've been naturally frightened at times of COVID and the issues around PPE, and is there enough of them, and are they going to get sick? But in spite of all of that, we've had overwhelming support, continued engagement within the Nightingale Challenge programme, and young nurses and midwives coming to us day in, day out to tell us how they want to make a difference. And we've got a particular project in Uganda with a place called Milcot that's really working with the local communities to try and improve the opportunities for young girls within that community by education, by training, by focusing on public health and prevention. And I have to say, it's one of the brilliant examples that we've got across the world of the ability for nurses to connect and be trusted by their local community. And we heard earlier, people not always trusting the health system. In the main, people do trust nurses and midwives because they're rooted in the local community. They're part of that local community, and they therefore can be the go-to person and the person that can get difficult messages across because they're seen as part of that infrastructure. And that opportunity in order for everyone to collaborate, to co-produce, and to make things better for each other. So it's a real privilege to be doing this work. I'm really delighted to say that the Nightingale Challenge is going to continue. We were initially, the Nursing Now programme and the Nightingale Challenge originally was due to complete in December, but because of COVID it's been extended to June. And we're now looking to extend the leadership development opportunity for young nurses and midwives all over the world to be extended for another 2 years, because the potential to get these people speaking, engaging, for people like yourselves, eminent people like yourselves, to have that resource to go to ask the questions, to work through the challenges, I think is going to be invaluable as we continue to drive this amazing global community and get them communicating and get them really being the change agents and being given the opportunities that they're absolutely up for and ready to do. So thank you so much for inviting me and allowing me to be part of this. And I really look forward to any questions and answers that you may have. Thank you, Professor Francis.
Oh, beautiful, Lisa. I do remember your visit here with a lot of warmth in my heart in February with Nigel and Annette Kennedy and so on. And when we talk about what we can take forward together collectively, this work on Nursing Now and the Nightingale Challenge, I think will rank very, very high in this. It's a major success already, and the future is great. And since your visit, the nursing leadership in Uganda did not have a formally appointed commissioner, or that's the chief nursing officer, for almost 5 years. But that has changed since, and that Beatrice Amuge is now sitting comfortably in that seat. And I was even just today exchanging emails with her about creating the new Federation of Nurse Professionals here in Uganda. So this is a positive and a very clear evidence of what works well and what we have been able to do together. So let's hear the Commissioner from the Ministry of Health. I think he's key in all this in Uganda, trying to grapple with a very complex, very, very complex situation. And right now there is debate about all cadres in Uganda, who is going to lead who and so on. So please, Mr. Okello, come in, please.
Thank you very much, Professor. I am delighted to be part of this debate, and I'll try to be as brief as possible. I've had problems with connectivity, but I hope you're hearing me.
Very well indeed.
Yes, Professor, I'll be addressing myself to collective actions that should be taken by countries to meet existing health force work challenges and demands in the next decade. Briefly, I would like to state the following: that actions that can be adapted by countries to meet the existing health in the decade will entail strictly 5 strategies, in my view. The first one is the need to enhance human resources for health financing, leadership, and governance. And under this, that in order to achieve this, we need to build budgets for human resources.
Your connectivity is an issue there. We're losing you.
Are you hearing me now?
Yes. Go on.
Yes. I don't know whether I'm heard now.
I can hear you. Yeah, we can hear you.
Yes. Now, the next action we can undertake is to cushion the health workers against economic shocks and economic depression due to pandemics and inflation. We also need to strengthen workforce leadership, governance for health, for human resources, for health systems resilience, responsiveness, and accountability. And in addition, we also need to emphasize human resources for health standards, ethics, and professionalism. Professor, the second strategy is to improve training for health, training and development for health workers. And under this strategy, we need to planning, implementation, monitoring, and evaluation of training and human capital development at all levels. We also need to strengthen the capacity for human resources for health regulation, because in Uganda, this area still has gaps, and not only in Uganda, but internationally, we're having gaps in this area. Further, we need to institutionalize realistic training and capacity building policies that address holistically the gaps that hinder efficient and effective performance in the use of technology by health workers. And in this, we should be be this third strategy is strengthening planning, policy analysis, implementation, and monitoring. And this calls for development of capacities for human resources for health policy stewardship and evidence-based planning, monitoring, and analysis. It also calls for enhancing workforce performance, productivity, improving morale and motivation, and also ensuring that we put in place mechanisms for reducing health work attrition. The other proposal is maintaining knowledge, a fair knowledge base and information base for the health workers right from the top up to the lower levels. Further, Chapman, we also need to realign investments in health workforce with the current and future needs of the population and of the health systems. And this should be done across the board, nationally, regionally, and internationally. The fourth strategy, Chairman, is to promote multi-stakeholder engagement and advocacy. Under this strategy, we need to establish stakeholder maps and strategic partnerships, including emphasizing community engagement. Because, for instance, under the current situation we are in, occasioned by COVID-19, the lesson is that we can only fight this pandemic if we strengthen the community-based approach. So, for all intents and purposes, emphasis should be placed on this. We also need to build for evidence synthesis, sharing, and use of the available information and of available ideas that can help us improve on the current quality of the human. And when I'm talking human quality, I'm also talking about, in addition to that, we also need to emphasize the need to having the right numbers, the quantity. This is the time also to embrace adaptive planning, monitoring, and accountability. And we also need to leverage partner capacity and to maximize synergies if we are to really address the challenge at hand. Strategy number 5, Professor, is standardizing staffing norms to address staffing gaps. And this calls for the need to ensure adequate quantitative and qualitative norms so that we are able to put in place both the numbers and we are also able to realize provision of qualitative services to the population. Under this strategy also, we need to emphasize career management and protection of health workers against infections, injustice, unfair treatment, and discrimination. Because the lessons learned clearly indicate that stagnation in employment demoralizes our health workers. So there must be room for professional growth. We also need to build capacity to scale up the use of wisdom. And lastly, we need to develop service delivery models to support task shifting. If I may summarize, I want to state that in conclusion, in order for us to address the issue of future health needs and demand, we need to thoroughly interrogate the expected future share in the national GDP, the provisions in the GDP. We must be able to explore the available financing for the workforce in future. We need to realign services that are available provided both by the private and the public sectors. All this will inform the strategies to be adopted. Professor, for now, I beg to stop here. Thank you.
Well, beautiful. In that short time, you summarized for us how you see your work in the ministry. And it is all very clear, very challenging, very, very challenging indeed. The question for me now is how do we tie all this up? You've also referred to the need for community engagement, and there was an earlier conversation in the earlier session on this topic. And what was not mentioned is that this week on Tuesday, the Prime Minister of Uganda launched the National Community Engagement Strategy for COVID here in Uganda, which lays out what needs to be done to establish village COVID task forces covering every like 5,000 units of population. We have already existing structures in the country for that, with including village health teams. But what they need now is to be empowered, and that strategy is there. Maybe we share this strategy with this group, and I think it's on the website of ACHEST. I happen to be the chair of the subcommittee on this. And also your talk, other people have asked for it. Can you post it on the chat group, or because some people didn't hear you? So I would very much like, as we conclude, we don't have very much time now, to ask that question again: what can we do together? Certainly the nursing now and the Nightingale Challenge, we are already working on that. Let's see how we can do more. I would also like to hope and want to advocate for Uganda and the UK to develop a bilateral agreement on sharing health workers instead of the situation which we have now. May those people in the Ministry of Health in Uganda and in the government of the UK, can we initiate this? The sooner we do this, the better. It is true, Ben, there are many unemployed health workers in Uganda, but also there are many vacancies in Uganda. So we need to help Mr. Okello, the commissioner there, to address these 5 lists of his. What is it that the government of the UK can do? I think some TA, direct TA to the office of the commissioner is something which I think could make a big difference right now. Maybe they don't need it, but in my view, they do. And it is something which we can consider to want to be taken forward together. Not to make our list very long, I think we could just stop at those 3, because if we achieved those, then this partnership would really be flying and achieving the goals for which it was set. So thank you for the opportunity to moderate this very important session. And I would like now to hand over to the organizers. Thank you very much, and so nice to see all of you old friends on this meeting. It's a great meeting, and we look forward to the next one. Thank you.
Thank you so much, Professor.
Thank you very much, Professor Omaswa, for the excellent moderation. I think we have some few minutes that the panelists can answer some of the questions, if that is okay with them. And
yes, we are all ears for that if we have time.
We have some time. We have some 10 minutes for the panelists to answer one question each. I can read them from the panelists from the chat, if that is okay.
Good. Go ahead, please.
The first question goes to, I think, all the panelists, including you, Professor Omaswa, and that is about what you just mentioned. There are many unemployed health workers in Uganda who are trained, and how could this be integrated into the healthcare system, delivery system?
Mm-hmm.
We could go for that first.
Okay, I think let's ask our colleague, Mr. Okello, to address that one first. I will also make a comment on it.
Indeed, we have health, and to absorb this, call for stronger collaboration between public and private sector. Because of today, government only able to employ about 50,000 health workers. The rest of the health workers can either be in the PNFs and in private sector institutions, because government structures are determined based on the availability of the wage bill and the ability to sustain those who have been recruited. So those who cannot be absorbed into these structures, the only way out is to try as much as possible to motivate the private sector to take them on. And indeed, if I had time, one of the recommendations which I was going to float was that for the private sectors who are willing to take on health workers, this is the time to encourage government to exempt them from certain taxes and incentivize them to take as more and more health workers as possible. For now, that's what I can say.
Okay, all right. My comment on that, my response on that is one. You, Patrick, mentioned about staffing norms. The population of Uganda has grown so much more than when the staffing norms were made. I think that was in about 1998, around there. And the health workers who are there, even if they are fully employed, would not be able to carry on the workload. You've talked about Wisen as well. The expenditure per capita on health by the government of Uganda has declined. When I was in the Ministry of Health, we were floating around $65 per capita. Today, we are around like 40, 45. And that is a big issue. And it is the reason why we cannot increase the staffing positions. It is the reason why the wage is low and not attractive. And it is the reason why many other things are happening. So I think we need to advocate for increased expenditure on health so that you can increase the staffing norms, review the staffing norms to meet the demand, the workload. And then the other point I think is within your hands. The Health Services Commission and the District Service Commissions, there are so many vacancies which they are not filling. Why are they not filling these vacancies? Of course, there will be many reasons. Some parts of the country are not popular. People don't want to go and work there. But there is, I think, that issue you can deal with the resources that you have. But the bigger one is increasing the staffing norms, reviewing them, increasing the incentives like you asked for, better conditions for civil servants. They were health workers, doctors were promised, is it 5 million shillings per month? 3 years ago when they were on strike, it hasn't happened. So those are things which we really need to face. And what can the UK do to help us with this challenge? Maybe Ben, will you come in on this?
What I am very drawn to is your proposal, Professor, about creating an ethical agreement between the UK and Uganda. And I know I've got, no seconds left to speak, but that's what I very much like to explore. It's the ethical movement of people with the full influence of government agreement by people like Professor Jed Byrne, who's just joined us again, that we really need in order to move forward and in order to outmaneuver those private recruitment companies that you criticized right at the beginning.
Okay, very good. Another question? Or does Patrick want to come back on what we have said?
Want to come in before I pose the next question?
Yes.
Please go ahead in the shortest time possible.
First, I tell your recommendation, and I would like to inform you that we are at the final stages of reviewing the existing structures for the health sector. And under this review, they're expanding to accommodate more health workers. Thank you.
Very good, very good.
The
next question,
next
please.
question had been passed on from the previous panel, which was about how health workers can be supported to drive the agenda for UHC. And the question was, what practical solutions can address the by health workers during the current pandemic?
Okay, is there a panelist who would like to deal with that? If not, really the key issues of health workers now, as I see them, I'm engaged with the COVID effort here in Uganda. One is they are getting tired. Two, the supply of PPEs. Three, they are qualified to receive extra duty allowances, which they are waiting for. Sometimes they say it takes very long to get them, or they don't come. And then their supervision support, so that they are visited regularly where they are. And then finally, I would very much like to see that the village health teams get that allowance of 100,000 shillings per month, so that they can monitor the households and support the response of the community to COVID. Those would be my suggestions. Maybe Patrick, you will have something also to say about that.
Yes, Professor.
Yeah.
I want to correct the question.
Yeah.
And we've been paying hardship allowances.
Yes.
Yeah, apart from some isolated cases.
Yeah.
Two, the PPEs have now been procured.
Yeah.
And we have told all the accounting officers, the various hospitals, to request for them.
Yeah.
And based on the previous advice Professor provided to us as a ministry, we have now developed guidelines for management of health workers who get infected with COVID-19. And in those guidelines, they are very, very clear. If somebody gets infected, government should be able to compensate. When somebody dies, we should be able to meet the bills. When somebody falls sick, we evacuate to the hospitals and offer the best medical services ever. Professor, I will share with you the guidelines. I think it's very imperative. But most importantly, I'm one of those who have always advocated for the popularization and the immediate implementation of the community engagement approach to scale down on the pandemic. Because if you do not empower the communities, this virus will continue ravaging us. But where you have an enlightened community, which is very, very well educated, well sensitized, then they will be able to identify, and even internally, they can be our watchdogs and they can be a trigger to the next level of support. So this is now an area which we should emphasize in the funding. And if the UK government can support us, especially in that area where the pilot is taking place. I was in Ngora in the beginning of this week, and indeed people are starting to appreciate communities where we are rolling out this strategy. People are wearing masks, and they indeed know it is a reality. And I think these are the kind of approaches we should start investing in more and more. And even then, where we are having staffing gaps, where we are having the VHTs, we should look for money to pay them, to motivate them, so that they are our foot soldiers in the fight against the pandemic. Professor, that's what I have to add. Thank you, sir.
That's brilliant, and congratulations. I'm aware that the ministry is doing everything possible. I also am aware that between the Ministry of Health and the Ministry of Finance, there are sometimes gaps in releasing the funds, but we need to make also the public aware that where there are delays, it is not deliberate. I know the PS is working on this non-stop.